Hello. On behalf of the Mountain Plains Regional Disaster Health Response System, I'd like to welcome you to this third in our series of weapons of mass destruction. My name is Peter Pons, and I am an emergency physician in Denver, Colorado. This module will review chemical weapons and, in particular, the various nerve agents that are out there. The photos that you see, particularly the one in the middle, is that of a victim of a chemical weapon. Now, while this presentation is going to focus on the terrorist use of these weapons, the reality is that we are much more likely to respond to a chemical incident as a result of a transportation related crash. So it might be a truck, might be a railway tank car, but the reality is that those are much more common than terrorist events. Ideally, what we would like to do is be able to recognize that, in fact, a chemical warfare agent has been used based upon the signs and symptoms that the victim is presenting with, and then institute the appropriate management. Now, the use of chemical weapons is unfortunately not something that is new. They have been used in warfare for literally millennia, and perhaps really got their most use in the 20th century. In World War I, the use of a variety of chemical agents was brought to a whole level. The photograph that you see is the release of chlorine gas over a battlefield in World War I. They have been used extensively in the Middle East. And a variety of terrorist uses have also occurred, most notably in Japan, and we'll talk about these. Aum Shinrikyo is a cult based in Japan that has utilized sarin in particular for a couple of attacks. Most people are familiar with the subway attack in Tokyo in 1995. However, that attack was actually preceded the year before in Matsumoto. The cult wanted to try and kill some judges who were hearing a case against them, and they converted a truck to be able to essentially release sarin gas outside the building these judges were located in. The end result was they killed 7. Another 280 or so had signs of sarin toxicity. Unfortunately, the judges they were targeting were not in the building at the time of the attack, and they were missed. The Tokyo attack obviously is one that got a lot more publicity, if you will. 12 were killed, 1,000 people were hospitalized with signs of sarin toxicity, but an additional 5,000 individuals who were concerned they might have been exposed sought care. 10% of first responders also sustained toxicity. This is a photo just outside the subway station in Tokyo. And if you look carefully at this photograph, besides the victims that you see, you'll notice that there's something you don't see, and that is the use of personal protective equipment by anyone. And it was this lack that resulted in 10% of the Tokyo Fire Department and some 25% of the receiving hospital personnel showing signs of sarin toxicity. Now, in fairness to them, this was 1995. We didn't think much about chemical attacks back then, but it's something now that we must have in our consciousness. From 2010 to 2015, this graphic shows you a number of the chemical attacks that occurred, most of them in the Middle East. And you can see chlorine was used, possibly sarin gas, pesticides, which are much like the nerve agents, various other agents, and large numbers of individuals injured and killed. Now, when we talk about the various chemical warfare agents, we classify them into four primary groups: the nerve agents, the vesicants, the industrial chemicals, or pulmonary agents, and riot control agents, which are included in this group. This first presentation is going to focus on the nerve agents, and we'll talk about those in some detail. And then our next presentation will discuss the other agents. When we talk about nerve agents, a couple of the important things to consider is how long that chemical will remain in the environment. That's called persistence. And it obviously depends on a number of factors, including the volatility of the particular agent, the ambient temperature. As you might guess, the warmer it is, the easier it is for the agent to volatilize and thus disperse. The presence or absence of wind, which will help with its dispersal, and then any interaction the agent has with the surface upon which it's been spread. This graphic shows you the various agents that are commonly used and their average persistence. If you look at the bottom half of this graphic, this is warm conditions. And by warm, it's relatively warm. It's 60 degrees Fahrenheit. You'll see that things like sarin and cyanide essentially disperse within 30 minutes or so. Soman and lewisite within a couple hours. Mustard agent and tabin, which is another nerve agent, about a day. And VX, because it is an oily substance, this nerve agent hangs around for about 3 days. As the temperature drops and it gets colder, which is what the upper half of this graphic shows, you can see the difference in how long these things hang around. Sarin, which in the warm conditions basically hangs around for about a half hour, will now be present for about 8 hours. VX, which would disappear in about 3 days in warm conditions, could persist for as long as a week, slightly longer. So the persistence is clearly affected by the temperature of the environment. Now, the nerve agents that we're going to review include tabin, sarin, soman, and cyclosarin. And you'll notice that the letters after each of those begin with a G. This refers to the NATO designation for these agents. And the G agents all were developed in Germany. All of them volatilize very easily and thus are easily dispersed. VX originated in the United Kingdom, and it, as I mentioned, is oily and volatilizes slowly. And the newest nerve agents are called the Novichok agents, and they are originated in Russia. The nerve agents are the most toxic of the man-made chemical agents. They penetrate skin, they penetrate mucous membranes, the eyes, the conjunctiva, and obviously can be inhaled into the lungs. The diagnosis of exposure to a nerve agent is one that must be made clinically. While it can be confirmed in a laboratory by measuring cholinesterase activity, this takes a significant amount of time, and typically we're not going to get that result back in the time frame we need in order to treat patients. So we have to recognize the clinical presentation and treat these patients accordingly. Now, on this penny, you see a white spot there. That amount of nerve agent, which for all of these would be a liquid, but that wouldn't have showed up on the picture. So they used a powder. But that amount of nerve agent is enough to kill 50% of the people it comes in contact with. Now, the Novichok agents, which is sort of Russian for newcomer, are designated the A agents, and you see them listed here. They were originally designed to be undetectable by standard analysis methods. They were designed to defeat the protective gear used by NATO, and they were designed to be safe to handle. And the way they were designed to be safe to handle was that it's a binary agent, meaning that two non-toxic chemicals are mixed together to create the active nerve agent. It's dispersed as an ultrafine powder. It is 10 times more lethal than VX. It is denser than air, so it will collect in low-lying areas. And if you survive the exposure, it may have long-lasting neurologic effects. This image shows you the normal nerve function. Acetylcholine is released from the nerve endings, and then acetylcholinesterase is then released to inactivate the acetylcholine and stop the propagation of a nerve stimulus. In this next image, we're going to see what happens when nerve agent comes along. The stimulus comes down, acetylcholine is released like before, but the nerve agent blocks the effect of the acetylcholinesterase. Acetylcholine accumulates, and the end result is overstimulation of the target organ. So that could be a nerve, it could be a gland, but the end result is overstimulation of the nerve. Now, cholinergic receptors fall into two groups: muscarinic receptors and nicotinic receptors. The muscarinic receptors are smooth muscles and glands. Smooth muscles, you'll recall, are found in the lungs. They're found in the GI tract. They're found in blood vessels. The glands include things like salivary glands, tear glands, etc. Nicotinic receptors are found in skeletal muscles and ganglia, nerve ganglia. Now, the reason this is important is because our antidotes target one or the other of the receptors, but not both. Now, the effect of overstimulation of the muscarinic receptors can be remembered by the acronym dumbbells. The D stands for diarrhea, U for urination, M for meiosis or constriction of the pupils, B for bradycardia, also bronchorrhea and bronchospasm, bronchorrhea being secretions in the lungs, emesis, lacrimation or tearing, and then salivation, secretions, and sweating. Another acronym that has commonly been used is the sludge syndrome, and we'll talk about that one in just a second. The nicotinic receptors are mydriasis, meaning pupillary dilation, tachycardia, weakness, hypertension, hyperglycemia, and muscle fasciculations. And these are sort of the days of the week: Monday, Tuesday, Wednesday. The sludge acronym, which was in common use before dumbbells, is salivation, lacrimation or tearing, urination, defecation, GI distress, and emesis. So muscarinic sites, increased secretions, that includes saliva and tears, runny nose, secretions in the airways, that can be extensive, secretions in the GI tract, and sweating. The smooth muscle contraction and the constriction of the pupils in the eyes. If you look at this series of pictures on the right, the top picture shows the day of exposure, day one, and you see the pupils are fairly constricted, and it took 60 days for the pupils to recover. Airways, Smooth muscle contraction in the airways causes bronchoconstriction, so you get shortness of breath, a picture that looks a lot like an asthma attack. In the GI tract with smooth muscle contraction, we see hyperactivity leading to nausea, vomiting, diarrhea. Skeletal muscles, we see fasciculations, twitching at the site of exposure. Eventually, this can progress to muscle weakness and full paralysis. And then other neurologic effects include tachycardia and high blood pressure. We can also see various cardiac dysrhythmias and heart blocks. And in the central nervous system, we can see loss of consciousness, seizures, respiratory arrest, and then prolonged effects include psychological effects. So how do we make the diagnosis? Well, two ways. One is based on the symptoms. If we recognize the presentation, the symptom complex, those symptoms that I just mentioned, a combination of those symptoms is highly suggestive of nerve agent exposure. The other is situational. When we see a number of casualties presenting with similar signs and symptoms, probably all occurring at about the same time, probably all of them occurring in a very similar location, we can then suspect that some sort of chemical release occurred. And depending on the symptoms that the patients present with, we can make the diagnosis of a likely nerve agent exposure. Now, we mentioned these agents can present either as a vapor or as a liquid. If we talk about vapor exposure, obviously the method of exposure is primarily going to be by inhalation. With a mild exposure, we'll see the pupillary constriction. Patients may complain that their vision seems dim, that they're having some eye pain. We'll see the runny nose. We may see some shortness of breath. As the exposure severity increases, the signs and symptoms increase. With a moderate exposure, we'll see increasing shortness of breath, the GI symptoms, nausea, vomiting, diarrhea, and muscle weakness. And with a severe exposure, if they inhale a lot of sarin vapor, for example, you may see immediate loss of consciousness, seizures, respiratory arrest, and paralysis. Vapor effects occur literally within seconds of exposure. The peak effect occurs within minutes, and there's no late onset. So if someone had a vapor exposure, they are transported to the emergency department. They're not showing you any signs or symptoms. They should be watched for maybe about a half hour. And if they still have no signs or symptoms, they're not going to develop any. With a liquid exposure, unfortunately, excuse me, the development of signs and symptoms can take significantly longer. With a mild exposure, which means typically liquid somewhere on the skin, you may see localized sweating around the site of exposure. You may see muscle fasciculations beneath the site of exposure. You do not see the pupillary changes. This can take as long as 18 hours to develop. With a moderate exposure, you'll see the GI tracts effects. And again, the eye findings are not common. With a severe exposure, typically those symptoms will occur within about a half hour. And that includes all the neurologic effects, loss of consciousness, seizures, respiratory arrest, paralysis, ultimately leading to death. Now, to treat someone who's been exposed to a nerve agent, airway management is going to be an important part of this. And remember, because of the bronchoconstriction and all of the secretions, it's a high resistance airway phenomenon that you're going to be dealing with. And then we want to administer the antidotes, atropine, 2-PAM chloride or pralidoxime, and diazepam. Now, the atropine antagonizes the muscarinic effects only. So what that means is the atropine will help dry up the secretions and it'll help relax the smooth muscles. It can be given intravenously, intramuscular, or down the endotracheal tube. It will not reverse the pupillary effects. It will not have any effect on the skeletal muscles, but it will help the secretions and it will help the smooth muscles relax. And that's important in terms of dealing with the airway issues. If you give it IV in a hypoxic patient, it may cause ventricular fibrillation. So you want to be sure that you've corrected any hypoxia at the same time that you're giving the medication. Starting dose is 2 milligrams. And if you think about our standard use of atropine, it's a fairly large dose. And you will keep giving atropine until the patient gets better. So in many cases, that can mean 10, 15, 20 milligrams or more. Okay. If this was an insecticide poisoning, which clinically is very similar to a nerve agent treatment, those require even more atropine. So a huge supply of atropine is required. Obviously, atropine in someone who's normal does have side effects, including dilated pupils, blurred vision, increased heart rate, and decreased secretions and sweating, the latter of which is clearly what we want to accomplish. How much do you give? You give it until the patient's better, which means until the secretions are dry and until ventilating the patient becomes easy. Okay. If you have not intubated the patient and the patient is awake and conscious till they're comfortable breathing. Do not rely on the heart rate to determine how much atropine you give, and most certainly do not rely on pupillary size because the atropine does not change that. 2-PAM chloride or pralidoxime works at the nicotinic sites. It has no effect at the muscarinic sites. So what it does is it helps remove the nerve agent from the acetylcholinesterase in the absence of aging. And we'll talk about aging in just a second. The treatment is to give 1 gram slowly over 20 to 30 minutes in an IV infusion. And if you give it too quickly, it'll increase blood pressure. And we'll talk about dealing with that in just a second. This left-hand graphic shows you what happens when 2-PAM is given. It breaks the bond between the acetylcholinesterase and the nerve agent. If aging has occurred, that bond becomes permanent and 2-PAM is not going to work. So if we talk about aging, how long does it take for that bond to become permanent? Well, if the nerve agent used was Soman, it takes about 2 minutes. Sarin, on average, about 4 to 5 hours, and VX about 60 hours. So you can see if the patient was exposed to Sarin or VX, we have a fairly nice window of opportunity to treat the patient with pralidoxime. If the patient was exposed to Soman, however, that bond becomes permanent in 2 minutes, and the pralidoxime will not reverse the effects of the Soman. Now, how will we know which nerve agent was used? Well, the simple answer is we won't. All of them will present the same. All of them will look the same. So the bottom line is we will give everybody who looks like a nerve agent poisoning treatment with 2-PAM, with pralidoxime. And in the unlikely event that they were exposed to Soman, it won't be effective. In the more likely event that this was Sarin or VX, the pralidoxime will be beneficial. And the third so-called antidote is a benzodiazepine, commonly Valium or diazepam, and it's used to treat the seizures associated with nerve agent poisoning. And the recommendation is that clearly if the patient's seizing, to use it. It's also recommended that in severely intoxicated casualties, whether they are seizing or not, go ahead and give the benzo because it reduces the brain injury associated with the seizures. Now, available for civilian use, it used to be only military use, is a Mark I kit. The Mark I kit are auto-injectors, and they contain both atropine and pralidoxime. The small auto-injector that you see labeled number 1 is the atropine. It contains 2 milligrams. The larger auto-injector labeled number 2 is the pralidoxime, and it contains 600 milligrams. Previously, it was 2 auto-injectors. Now there is a single auto-injector available called Duodote, and Duodote contains both the atropine and the 2-PAM in a single device. The military version of the Duodote is not labeled Duodote. It's labeled Antidote Treatment Nerve Agent Auto-Injector, ATNA. And so if you see this, it's exactly the same as the Duodote. It is just the military labeled version. So let's summarize treatment. If someone presents with no signs or symptoms, reassure them and observe them. If it was a vapor exposure, watch them for an hour. If they still have no signs or symptoms, they can be discharged. If it was a liquid exposure to the skin, they're going to need to be watched for 18 hours to be sure the symptoms don't develop. The photo that you see here of Nicolas Cage is from the movie The Rock. And the round things that you see were meant to represent nerve agent. He inadvertently drops one in the movie, becomes exposed, and pulls out his antidote and gives himself a intracardiac injection. I would urge everyone to resist that urge. Not the ideal therapy. For a mild vapor exposure, and that's defined as the pupillary findings of constriction, some runny nose, you're going to watch them. If they develop shortness of breath, increasing shortness of breath, we'll treat them. And mild liquid exposure with fasciculations and sweating at the site of exposure, we're going to treat them. And treatment can be 1 MARC 1 kit, both the atropine and the 2-PAM, or you can draw up these medications and you can give the atropine either IM or IV, and the 2-PAM, and if you draw it up, you'll draw up 1 gram intravenously. For a moderate exposure, the symptoms are worse, you'll probably give 2 MARC 1 kits, or if you're drawing it up, 2 to 4 milligrams of atropine and that gram of 2-PAM. And for a severe exposure, we're going to start off right off the bat with 3 MARC 1 kits. So that's 6 milligrams of atropine. And if you have an IV, you'll give the 2-PAM intravenously. They're also going to need their airway managed. They'll probably need ventilation. Severe exposures ought to be treated with the diazepam. And then you'll repeat atropine every 5 to 10 minutes until the secretions have dried. And if you've intubated the patient and you're bagging them, until the bagging becomes easy. The 2-PAM can be repeated in 1 hour. Of course, for children and the elderly, we'll adjust the dosages, and they're listed here. I'm not going to read the slide to you. You can look this up in the event of an incident. Same with the 2-PAM. I mentioned that hypertension is a complication if you give the pralidoxime too quickly, and treatment for that is phentolamine in the doses as shown on this slide. Diazepam also, of course, is adjusted based on the age. Now, let's talk a little bit more about the auto-injectors because there is some knowledge about those that everyone should have. Number one is they're simple to use. You get accurate drug administration. They're pre-measured. You don't have to deal with drawing up a medication. They are fully automatic. They're pretty rugged. They come available for atropine, pralidoxime, and 2-PAM. And they also come with pediatric sizes. And the FDA has approved them for civilian use, where previously they were only approved for the military. And while we are focusing on nerve agent use, they can also be used for the organophosphate insecticides should someone become exposed to those. Now, in order to use an auto-injector, step one is to remove the safety cap. The safety cap is located at this end of the auto-injector, which is sort of the non-business end. The important thing to remember is that once you have removed the cap, the auto-injector is armed and dangerous. It can deploy. And if you're using Mark 1 kits, the two auto-injectors, atropine and 2-PAM, come in a holder, in a clip. And the minute you pull the auto-injector out of the holder, the cap comes off at the same time. Okay. If you inadvertently deploy the auto-injector, okay, for example, you accidentally put your finger over that end and you deploy it, a spring-loaded needle will be extruded, and that spring-loaded needle is strong enough to go right through the phalanx of your finger. So handle with care once the cap has been removed. It's recommended you hold the injector like a pen, as shown in this upper illustration. You place the colored end of the auto-injector on the thickest part of the anterolateral thigh, and then you push down on it until the auto-injector deploys. That pressure will activate a spring that plunges the needle into the muscle and then forces medication through the needle into the muscle tissues. So an IM injection. You should hold the auto-injector in place for about 10 seconds to assure that all of the medication has been injected. You can then remove it. You can gently massage the area of the injection, and then dispose properly of the auto-injector with the deployed needle. Okay. And then somewhere you need to note the dosage that was given or the number of auto-injectors that were given. So if a triage tag has been applied to the patient, put it on the triage tag. If not, you can take a piece of adhesive tape, put it on the chest or forehead of the patient, and write what you gave on the tape. Now, this graphic shows the absorption of atropine based on heart rate measurement given various routes. This left-hand graph right here, the long dash followed by the dot, this is atropine that has been given by an intravenous injection. Okay? And you can see that at time 0, which is the moment of the injection, atropine is causing an increase in heart rate literally within a minute or two. Okay. The solid line that you see is atropine given by a standard manual intramuscular injection. And you can see that it takes about 10 minutes to get decent absorption of the atropine for us to see heart rate start to increase. And then the middle one here, which is the dashed line, is atropine that's been given by an auto-injector. And you can see that we start to see a response within 5 minutes, and the maximal response that we see is well faster than a standard IM injection. So the auto-injectors are a very reasonable approach to giving these antidotes. Now, how much antidote does your hospital have? Well, the federal government has created a program called the CHEMPACK program, which comes managed by the Centers for Disease Control. And the CHEMPACK project is basically designed to deploy chemical antidote to cities and states in advance of a chemical attack, so they have adequate supplies to manage casualties. When it gets deployed to a state, there has to be a designated lead agency. In many states, that is the State Department of Public Health. They oversee the receipt of the CHEMPACK assets, its distribution, its storage, maintenance, and potential deployment. There are obviously supporting agencies, and those are likely the local partners who will be responsible for using it in the event of an incident. Now, all of the CHEMPACK supplies remain part of the strategic national stockpile. Even though they're deployed to the states, they're still property of the federal government. They are just considered forward deployment. The Centers for Disease Control are the responsible federal organization. They have deployed about 2,000 of these CHEMPACKs in over 1,000 sites in all 50 states in the US. Those sites that store the CHEMPACK have a number of responsibilities. The location has to be climate controlled. By keeping it climate controlled, what the federal government will then do, along with the CDC, is extend the shelf life of the medications in there beyond their printed expiration date. The storage site has to have electrical power with backup. There has to be a security system in place so that access to the CHEMPACKs is controlled. There is an intrusion alarm with a security response and a telephone line alarm that goes directly to the CDC, and fire detection alarms. The site has to determine who is authorized to access this. If a CHEMPACK is used, they are responsible for notifying the CDC and the US Marshal's Office. And if you do access it, you will get a visit from the Marshals. And you are responsible for providing mutual aid in the event an incident occurs. The CHEMPACK storage site can designate personnel who can deploy it as necessary. And the activation of it is purely a local determination. You do not have to get CDC approval prior to using these materials, depending on the size of the incident. If this is an accidental exposure, let's say, it's someone who was using an insecticide, they expose themselves. They do want you to use your local available supply of antidote first before accessing the CHEMPACK, but you are allowed to access the CHEMPACK if the need for antidote exceeds your available supply. So use is pre-authorized. As I said, you don't have to give them a call in order to access this when the situation is appropriate. Now, in the event of a special event, particularly national security events, the state is authorized to move its deployed CHEMPACKs for special events on a temporary basis. So if, let's say, the city of New York was having a special event and it needed to have additional CHEMPACK assets pre-positioned, the state of Pennsylvania, for example, can move some of its assets to New York. Now, there are two different types of CHEMPACK containers, a hospital container and an EMS container. The hospital container contains more bulk packaged antidote, whereas the EMS container contains more auto-injectors. And the formulary for both assumes the following. It assumes that 30% of the cases will be mild exposures. It assumes 40% will be moderate exposures, and another 30% will be severe exposures. The hospital CHEMPACK is capable of treating approximately 1,000 patients, depending on the severity. It's mostly bulk packaged, as I said, so medication would need to be drawn up. And it does have some Mark I kits for use. The EMS pack, CHEMPACK, contains supplies for approximately 450 patients, again, depending on the severity of those patients, and it's mostly auto-injectors. So Mark 1 kits, as the Mark 1 kits expire, they're being replaced by duodotes, both in adult and pediatric doses. If you do access these CHEMPACKs, you may notice that the diazepam auto-injectors are not labeled diazepam. They are labeled CANA, C-A-N-A. CANA stands for convulsive antidote nerve agent. And that is the military terminology, again, for the use of the diazepam. On the photograph that you see, this is the CHEMPACK container. They are on wheels for easy movement. Each of these is sealed. It is wired for security. And the minute you open up the CHEMPACK, if you remove the door to the CHEMPACK, the container automatically dials the CDC to let it know that somebody has gotten into the container. This video will demonstrate opening the door. We're breaking the seal, sliding the locks over, lifting the door out. At this point, the container will be calling the CDC. And you will then get a call from the CDC if you haven't already notified them to inquire what's going on. And you will likely get a visit from the marshals to also see what's going on. So to summarize nerve agent exposure, vapor exposure, the symptoms develop very quickly within seconds and peak within minutes. Most ambulatory victims require minimal intervention, primarily observation. The risk of secondary contamination to healthcare providers is relatively small and can be minimized by removing the victim's clothing so that any retained vapors are removed. And for those that do have symptoms, you need immediate access for the antidotes. Patients who have liquid exposure, the symptoms will be delayed and typically take minutes to hours, and in many cases, as much as 18 hours. There's a greater need for formal decontamination to wash the material off the skin. There's obviously a higher risk of secondary contamination because of the liquid that is on the skin. So clothing's got to be removed. The patients have to be decontaminated. And once again, access to antidotes is essential. Thank you for your participation in this module, and we hope you take a peek at our additional modules.